Hello everyone, greetings of the day. I'm Dr. Manmeet Kaur. I'm MDS in periodontology and oral implantology. So I'm going to cover the periodontal pocket, the topic which is very important uh, for MCQs in the NEET MDS preparation and in clinical dentistry also. So I hope that I can make this topic a little more understandable for you all. So starting with the introduction. So periodontal pocket is basically the gingival, a deepening of the periodontal sulcus. So this is a pathological deepening. Okay, so generally, by the definition, pathological deepening of the gingival sulcus is known as the gingival periodontal pocket. It is the most important clinical features of the periodontal disease. A periodontal disease, whenever we come across a periodontal pocket, we measure the periodontal pocket using the periodontal probe. That is, mostly we use UNC 15. So there is always a space or a depth of 1 to 2 mm that is present in between the gums and the tooth. So that is physiological. When there is deepening of this normal gingival sulcus, then this physiological depth is converted into a pathological depth, and this becomes a periodontal pocket. So classification, deepening of the gingival sulcus is possible because of in two ways. Now the gingival, whenever you probe, so in two ways you can get a deep gingival sulcus. How? So whenever there is a coronal movement of the gingival margin, imagine the case of gingival enlargement. So in case of gingival enlargement, the gingiva moves coronally. So in that case, this is known as the pseudo pocket or gingival pocket, because the junctional epithelium or the dentogingival unit is intact, but the deepening of the gingival sulcus is due to the coronal movement of the gingival pocket, while periodontal pocket results in the when there is apical displacement of the complete dentogingival unit, that is the junction epithelium. So, and there can be a combination of the two, which is there is also gingival enlargement and there is also apical deepening of the apical displacement of the gingival attachment. Now, this was based on the pathogenesis. We have gingival pocket and we have periodontal pocket. So, gingival pocket is a pseudo pocket. It is formed by the gingival enlargement with no periodontal destruction of the underlying tissues. So, no periodontal structure is destruction is there in case of gingival pocket. This is just because of the uh, coronal movement of the gingiva. In case the most common example is gingival enlargement. Now, what happens in periodontal pocket? Periodontal pocket occurs with destruction of periodontal tissues. So basically, it is two type. The most common question that comes is the types of periodontal pocket, difference between suprabony pocket and infrabony pocket, and there is a lot of confusion in this. So I'll be explaining this in thorough detail. Now, what is suprabony pocket? In suprabony pocket, the bottom of the pocket is coronal to the underlying bone. Now, you can see in this picture, as you can see, I hope you're able to see. Now, this is the most coronal part of the bone. This is the most apical part of the pocket. So, the bottom of the pocket is coronal to the bone. So, this is a suprabony pocket. Number A, what is this? Can anyone tell? This is the coronal displacement of the gingiva. So this is the gingival pocket. You can see all the periodontal structure. This is the junction epithelium. This is the bone. This is the cementum. These are the PDL fibers. Everything is intact. So this is a gingival pocket or a pseudo pocket. This is a suprabony pocket, and this is infrabony pocket. Now, this is the most coronal part of the bone, and this is the apical end of the pocket. So, the bottom of the pocket is apical to the bottom of the pocket is apical to the bone. So, this is Infrabony pocket. What is an infrabony pocket? The bottom of the pocket is apical to the level of adjacent alveolar bone. So you have to remember these two terms, coronal and apical. Based on the tooth surface involved, so these are three types of pockets: simple, compound, and complex. A simple pocket involves only one surface. The compound pocket involves two surfaces, like more than one surfaces. There will be mesial surface involved and distal surface involved. What is a spiral pocket? Spiral pocket starts from one surface and ends on the other surface. So it involves more than two surfaces, is a complex or a spiral pocket. So because of this reason, I would like to explain a clinical significance on the basis of the tooth surface involved. What is the clinical significance of this classification? Clinical significance of this classification is whenever you probe a pocket, you always do walking of the probe inside the pocket, because there might be many surfaces involved around the tooth. So you always put the probe inside and take it out, not completely take it out of the sulcus, just elevate it a bit, put it back. So this is walking of the probe inside the pocket. So you get to know whether it's a simple pocket, whether it's a compound pocket, or whether it's a complex pocket. Now, the clinical features of the pocket, basically the clinical features, the gingival pocket, it appears to be bluish red, and there is always, or most commonly it is associated with bleeding, suppuration, that is there might be pus discharge, there might be tooth mobility, there might be diastema formation due to pathological migration, and there could be a localized deep pain in the bone. Now, the correlation of clinical features and histological features. Okay, so why is the gingiva around the periodontal pocket, why it is bluish red in color? Why it is not, you know, bright red in color? So it is bluish red in color because of the stagnation of the blood in that area. Why? Because the blood is stagnate, there is stagnation because there is so much of engorgement of the blood, then that the area around that, the blood around that area is stagnant and it appears to be bluish red. Then the tissues are flaccid. Why? Because of destruction of the fibers. The flaccidity is gone. Then why smooth and shiny surface is present of a periodontal pocket? Because of the atrophy of the epithelium. Why is there pitting on pressure? Because of edema. There is so much of fluid accumulation and blood accumulation inside the tissues that it pits on pressure whenever you put a probe. So it will take the shape, and then like in pitting edema. So it's same is in the case of periodontal pocket. And the gingiva is firm and pink because of fibrotic changes. If the gingiva is firm and pink, so that is because there are fibrotic changes are more and destructive changes are less. There is more fibrous, more connective, more collagen formation is there. If there is a case of periodontal pocket with firm and pink gingiva, so that is a fibrotic pocket. Okay. Now, bleeding on probing. Why there is bleeding on probing? Because there is increased vascularity, there is increased number of blood vessel, and there is thinning and degeneration of the epithelium. So whenever there is the epithelium is thinned and it is degenerated, therefore, whenever you put a slight pressure, बिकॉज एक तो वेस्कुलरिटी बढ़ी हुई है और जरा सा भी आप प्रेशर डालेंगे इवन प्रोब का, तो एपिथेलियम तो वहां का थिन और डीजनरेट और अल्सरेटेड हो ही रखा है, तो जरा सा भी प्रेशर से वो ब्लीड करना शुरू हो जाता है। और इतनी एनग्रॉस्ड वेसल्स होती हैं कि whenever you put the periodontal probe on small probing and little force also, it starts to bleed because it's all ulcerated, all degeneration of epithelium हुआ होता है वहां पे। Then why is there pain when you probe the periodontal pocket? Because there is ulceration of the inner surface of the pocket, and there is pus because of the inflammation. There is pus discharge. That's it. Pathogenesis, initial lesion, there is inflammation of the gingiva, there is bacterial challenge. Now, what happens, I'll like to explain pathogenesis in a bit more detail. What happens is, suppose there is plaque accumulation. Teeth के around plaque accumulate हुआ, patient ने brush नहीं किया. या आप सोच लो कि सब जिंजाइवल प्लाग एक्यूमुलेट हुआ, पेशेंट का वहां पे ब्रश पहुंच ही नहीं पा रहा है. सो व्हाट हैपेंस, इनिशियल इन्फ्लेमेशन हुई, न्यूट्रोफिल्स आए वहां पे, और सपोज इफ पेशेंट ब्रशेस और द प्लाग इज रिमूव्ड, द clinical features are, or there is no disease progression. Okay, now if the accumulation of plaque is increased over time, so there will be more and more neutrophils in that area as a result of transmigration because of inflammation. वहाँ पे neutrophils आएंगे. So the important number is 60%. जब neutrophils का number 60% या neutrophils का volume 60% या उससे ज़्यादा हो जाएगा, then there will be धीरे धीरे डिस्ट्रक्शन शुरू हो जाएगा, और कोरोनल एंड से जिंजाइवल जो जंक्शनल एपिथेलियम है उसका डिस्ट्रक्शन शुरू होगा, एंड देन देयर विल बी पॉकेट फॉर्मेशन. Okay, so this is a very important feature of periodontal pocket pathogenesis कि जो neutrophils का number है, it should be neutrophil volume of neutrophil should be more than 60%. Now coming to histopathology. Now in soft tissue wall, the connective tissue edematous होएगा, infiltrated with plasma cells, lymphocytes and PMNs. Blood vessels are increased. There is degeneration. Necrosis is present. Proliferation of endothelial cells, newly formed capillaries, fibroblasts. Everything is happening, and this is a soft tissue wall of the periodontal pocket. Now what happens? Junction epithelium becomes short. The coronal-apical length is reduced to only 50 to 100 micrometers. So there are more degenerative changes along the lateral wall. The epithelial buds, they projects into the adjacent connective tissue. The densely infiltration of leukocyte, and there is edema, and there is vacuolar degeneration, which lead to ulceration of lateral wall and suppuration. Now, bacterial invasion, passive translocation of the plaque bacteria is there. You'll find P. gingivalis, Prevotella intermedia, AA comitans, there are filament, rods, cocci, all these things are present in the periodontal pocket when there is bacterial invasion inside the gingival epithelium. तो जो भी प्लाक का बैक्टीरिया होगा ना, वो प्लाक का बैक्टीरिया क्या करेगा, अपाइकल और लेटरल वॉल ऑफ द पॉकेट और बेसमेंट मेम्ब्रेन में सब एपिथेलियल टिश्यूज में चला जाएगा, क्योंकि अल्सरेशन हो रखा है. तो जो प्लाग है, आप इमेजिन करो, प्लाग सिर्फ सीमेंटम पे थोड़ी लगा रहेगा, टूथ की रूट सरफेस पे थोड़ी लगा रहेगा. जब इतना अल्सरेशन होगा तो ऑब्वियसली ट्रांसलोकेट होके प्लाग का बैक्टीरिया जिंजाइवल एपिथेलियम के अंदर पॉकेट की जो लेटरल वॉल है, अपाइकल वॉल है, वहां से इन्वेट करेगा ही करेगा टिश्यूज में. सो बेसिकली माइक्रोटोपोग्राफी ऑफ जिंजाइवल वॉल में क्या होगा, several areas with different type of activities, area with irregularly over or elongated, 20 to 50 to 200 micrometers. So there is a constantly changes pocket wall, and there is interaction between host and bacteria. Different types or different areas of pocket wall. अब क्या हो रहा है कि suppose this is the tooth and this is the gingiva, ठीक है. अब इस ये जो पॉकेट बनी हुई है इनके बीच में, so there are many areas from the coronal end to the apical end. It is divided into these 7 areas. Okay, these are the 3 and these are the next 4 areas. तो सबसे ऊपर क्या होता है, there is area of relative quiescence. So the flat surfaces with minor depression and mounds, occasional shedding of cells, areas of bacterial accumulation is there. Second is the area of bacterial accumulation. Third is the emergence of leukocytes. सबसे पहले क्या हुआ, relative quiescence में अभी कुछ नहीं हो रहा है, occasional cells वहां पे सबसे ऊपर shed होते जा रहे हैं. Then second area में क्या है, जहाँ पे बैक्टीरिया है. थर्ड एरिया में क्या है, बैक्टीरिया है, तो उसको उसके सामना करने के लिए कौन आ गए हैं, ल्यूकोसाइट्स आ गए हैं. तो थर्ड एरिया में देर इज एमर्जेंस ऑफ ल्यूकोसाइड। अब बैक्टीरिया भी आ गए, ल्यूकोसाइड भी आ गए, तो नेक्स्ट एरिया क्या होना चाहिए, इनका इंटरैक्शन। ओके, सो एरियाज ऑफ ल्यूकोसाइड एंड बैक्टीरियल इंटरैक्शन। अब ये इंटरैक्ट करेंगे तो तबाही ही मचाएंगे। सो द नेक्स्ट एरिया इज एरिया ऑफ इंटेंस एपिथेलियल डीस्क्वामेशन। अब इन दोनों ने आपस में लड़ाई करके क्या किया, एपिथेलियम का डीस्क्वामेशन कर दिया, अल्सरेट कर दिया एपिथेलियम को, और फिर खूनो खून। Okay, so isn't, like, I hope you understood, it is a, like, in a light way of explaining the areas of bacterial interaction, but I hope the message is conveyed. So different areas of pocket wall, can we revise it again? First is the area of relative quiescence, in which there is flat surfaces with minor depression and mounts, and there is occasional shedding of cells. Second is bacteria has come. So depression, penetrating intercellular spaces. Bacteria is penetrating intercellular spaces. अगर बैक्टीरिया आया है तो थर्ड ल्यूकोसाइट आ गए, ल्यूकोसाइट आ गए तो इनका इंटरैक्शन हो गया। अब इन्होंने लड़ाई धड़ाई करके क्या किया, देयर इज इंटेंस एपिथेलियल डीस्क्वामेशन which leads to ulceration and hemorrhage. Okay, so this is the different areas of pocket sole. This is scanning electron microscope, same picture, which is always black and white in color. So nothing to be explained in this. Now, pocket as a healing lesion. Now, it's a like ever going debate कि pocket कभी heal होती है? No, pocket can never heal. Pocket is constantly going undergoing repair, and complete healing does not take place because there is persistence of bacterial attack. Condition of soft tissue wall में क्या होता है? There is interplay of, जो भी हमारी soft tissue wall है उसमें हमेशा दो चीजें चलती रहती है, डिस्ट्रक्टिव और कंस्ट्रक्टिव चेंजेस। जब कंस्ट्रक्टिव चेंजेस ज्यादा होंगे तो हमारा फाइब्रोसिस हो जाएगा और पॉकेट की जो वॉल है वो फाइब्रोटिक हो जाएगी। जब डिस्ट्रक्टिव चेंजेस ज्यादा होंगे तो हमारा क्या होगा, अल्सरेशन हो जाएगा और पॉकेट की जो वॉल है वो बहुत ही फ्लैसिड होगी, अल्सरेटेड होगी। सो द बैलेंस डिटरमाइंस द क्लिनिकल फीचर सच एज कलर, कंसिस्टेंसी, सरफेस टेक्सचर एंड द ऑफ द पॉकेट वॉल। सो अगर ये बैलेंस बना हुआ है तो मतलब अगर सपोज दिस इज कंस्ट्रक्टिव, दिस इज डिस्ट्रक्टिव, अगर डिस्ट्रक्टिव चेंजेस ज्यादा है तो कलर होगा हमारा रेड, रेडिश पिंक कलर होगा, रेडिश कलर होगा, कंसिस्टेंसी बिल्कुल सॉफ्ट एंड एडिमेटस होगी, और सरफेस टेक्सचर भी बिल्कुल पिटिंग उसमें प्रेजेंट होगी, पिटिंग एडिमा एडिमेटस होगा। ओके, इफ द कंस्ट्रक्टिव चेंजेस आर मोर देन कलर विल बी अ बिट पिंक इन कलर। ओके, इट विल पिंक, क्योंकि रेड नहीं होगा क्योंकि तब फाइब्रोसिस ज्यादा हो जाएगी, कंसिस्टेंसी भी सॉफ्ट फर्म होगी, फर्म कंसिस्टेंसी होगी। ठीक है, सो पॉकेट एज अ हीलिंग लीजन में आपको यही समझना है कि पॉकेट कभी भी हील नहीं होगी और पॉकेट में हमेशा ही कुछ ना कुछ कंस्ट्रक्टिव और डिस्ट्रक्टिव चेंजेस चलते रहते हैं। So this is a basically just destructive changes में क्या होता है, if inflammatory fluid and exudate predominate the pocket wall, then bluish red soft spongy friable with smooth shiny surface. So clinically ये pocket wall कैसी होगी, edematous. Constructive changes जब होंगे, so if newly formed connective tissue cells and fibers predominant, so they will be more firm and pink pocket wall. It is referred to as fibrotic pocket wall. Okay.
Yes. Mama. Mama. Mama.
So these are the destructive changes and constructive changes. Okay, so edematous and fibrotic pockets represent opposite extreme of the same pathologic process, not different disease entities. So अगर आप सोचो कि edematous pocket अलग चीज, अलग disease है और fibrotic pocket अलग disease है, no, these are the opposite extreme of the same pathologic process, and these are not the different disease entities. So it's subject to constant modification and depending upon the relative predominance of exudative or constructive changes, it leads to the different clinical presentation of the same disease. So एक disease है पेरोडोंटाइटिस, और उसका एक क्लिनिकल प्रेजेंटेशन है पेरोडोंटल पॉकेट। पेरोडोंटल पॉकेट एडेमेटिस भी हो सकती है या फाइब्रोटिक भी हो सकती है, डिपेंडिंग अपॉन द कौन सा चेंजेस पॉकेट वॉल में चल रहे हैं। नेक्स्ट इज पॉकेट कंटेंट्स। पॉकेट में क्या क्या कंटेंट्स हो सकते हैं? सो बेसिकली माइक्रो ऑर्गेनिज्म एंड देयर प्रोडक्ट्स, जिंजाइवल फ्लूइड, फूड रेमिनेंट्स, लाइवरी म्यूसिन, डिस्क्वामेटेड एपिथेलियल सेल, ल्यूकोसाइट। Pocket contents. So basically, purulent exudate consists of living degenerated necrotic leukocytes, living and dead bacteria, serum, and some amount of fibrin. What is the significance of pus formation in pocket? Pus formation कुछ नहीं है, एक common feature है of periodontal disease और एक secondary sign है, ठीक है? Presence of the pus does not indicate the severity of the disease, not at all. एक common inflammation होगी, inflammation में destruction होगा तो pus form होगी, suppuration होगा। ऐसा आप नहीं बोल सकते कि जो पॉकेट अगर पस डिस्चार्ज हो रहा है तो बहुत ही डिस्ट्रक्टिव पेरोडोंटल डिसीज चल रही है या बहुत ही सिवियर पेरोडोंटाइटिस का केस है। नो, द पस फॉर्मेशन इज ओनली अ सेकेंडरी साइन, क्योंकि अगर इन्फ्लेमेशन होगी, इन्फ्लेमेटरी नेचर, इन्फ्लेमेटरी चेंजेस हो रहे हैं पॉकेट वॉल में, तो वहां पे पस फॉर्मेशन होगी ही होगी। सो नाउ वी हैव लर्नड अबाउट द सॉफ्ट टिश्यू वॉल के चेंजेस, ठीक है, जो हमने एरियाज आपको बताई, सब कुछ बताया, दीज आर द सॉफ्ट टिश्यू वॉल। नो, व्हाट अबाउट द रूट सरफेस वॉल? रूट सरफेस वॉल विल आल्सो अंडरगो सम चेंजेस और नॉट? सो व्हाट हैपेंस इन रूट सरफेस वॉल? जो हमारे सीमेंटम में कोलेजन फाइबर्स हैं, दे आर डिस्ट्रॉयड. So once they are destroyed, the cementum is exposed to the oral environment, and remaining of the Sharpie's fibers, they also degenerate and they creates environment for the bacterial penetration. तो जैसे हमारा बैक्टीरिया हमारे एपिथेलियम के अंदर इन्वेड किया था, उसी तरह हमारा बैक्टीरिया, because of the destruction of the collagen fibers and because of cementum getting exposed to oral environment, it creates the environment for bacterial penetration. And there is penetration and growth of bacteria. There is fragmentation and breakdown of cementum. Then there is areas of necrotic cementum that are separated from the tooth by bacterial masses. So root surface wall में क्या होता है? There are pathological granules represent the area of collagen degeneration or areas of not fully mineralized collagen. There are bacterial products such as endotoxin, and there is a softening of the cementum. Now, decalcification and remineralization of cementum. There are areas of increased mineralization result of an exposure to oral cavity. So minerals increased in disease include calcium, magnesium, phosphorus, fluoride. Micro hardness of the cementum remains unchanged. Then there are areas of demineralization, उसमें root caries हो सकती है, ठीक है, tends to progress around rather into the tooth. Active root caries well defined yellowish or red brown areas होते हैं, और inactive areas में dark lesions होते हैं root caries में, and that is hard in consistency. So what are the dominant microorganisms that are causing root caries? Actinomyces viscus, A. lundi, S. mutans, S. salivarius, etc. Now, surface morphology of the tooth wall. So, zones found at the bottom of the pocket. I think it will be better explained by this picture. So, this is the tooth surface. Okay, this is the zones found at the bottom of the pocket. तो सबसे ऊपर क्या होगा? हमारा cementum, ठीक है, उसके ऊपर हमारा attached plaque. Then there will be unattached plaque. Then there will be junctional epithelium. Then these are the partially lysed connective tissue fibers, and these are the intact tissue fibers. Okay. So cementum, attached plaque, unattached plaque, attachment of junctional epithelium, and semi-destroyed connective tissue fibers, followed by attached or intact connective tissue fibers. So these are the zones found in the bottom of the pocket. And what was the areas? यहाँ पे जो हमारा tooth surface है उसके zones है, ठीक है, और जो हमारा areas है, that I have explained you. Areas of quiescence, then areas of bacterial invasion, okay, that all that I told you, interaction, okay. Now, periodontal disease activity. Earlier, periodontal disease slow and continuous progressive phenomena कहते थे, but according to concept of specificity of bacteria, pocket go through the periods of excavation and quiescence, which are episodic bursts of activity followed by periods of remission. तो ऐसा होता है कि अब क्या burst में या episodic periods में होती है activity और remission. So this happens in burst now. ओके, सो पीरियड्स ऑफ क्विसेंस या इनएक्टिविटी में क्या होता है, सब कुछ रिड्यूस हो जाएगा, इन्फ्लेमेटरी रिस्पॉन्स रिड्यूस हो जाएगा, कनेक्टिव टिश्यू लॉस नहीं होगा, बोन लॉस नहीं होगा, और ग्राम पॉजिटिव बैक्टीरिया प्रीडोमिनेट करेंगे. सो ये डिसीज मतलब इनएक्टिव पॉकेट है. इनएक्टिव पॉकेट ना ब्लीच नहीं करती कभी. इनएक्टिव पॉकेट में कि जितना आपने पेरोंटल डेप्थ है वो इंक्रीज या प्रोग्रेस नहीं करेगी विद टाइम, और ग्राम पॉजिटिव बैक्टीरिया होंगे, कोई भी डिसीज कॉजिंग या ग्राम नेगेटिव पेरियोपैथोजेनिक बैक्टीरिया नहीं होंगे इन द पीरियड ऑफ इनएक्टिविटी. अब पीरियड ऑफ एक्टिविटी में क्या हो जाएगा, पीरियड ऑफ एक्टिविटी में सब कुछ उल्टा हो जाएगा. कनेक्टिव टिश्यू लॉस होगा, बोन लॉस होगा, एनारोबिक बैक्टीरिया प्रीडोमिनेंट एंड लास्ट फॉर डेज, वीक्स और मंथ. ओके, नाउ साइट स्पेसिफिसिटी क्या है इसमें, कि पेरोंटल डिसीज क्या है, बहुत साइट स्पेसिफिक होती है. जो पेरोंटल डिस्ट्रक्शन अकर्स ऑन अ फ्यू टीथ एट अ टाइम और सम एस्पेक्ट ऑफ सम टीथ एट अ गिवन टाइम. Sites of destruction often found next to the site with little or no destruction. So what happens? Severity increases with the development of new disease site and increased breakdown of existing sites. What are the associated pulp changes? So involvement of pulp in periodontal disease occur through the apical foramen या lateral canals, या फिर atrophic and inflammatory pulpal changes इसमें occur हो जाते हैं, because retrograde pulpitis जो हो जाता है because of periodontitis. Okay. Now, relationship of attachment loss and bone loss to the pocket depth. Now, just have a look at the picture. A, B और C. इसमें क्या common है? इसमें कॉमन जो चीज है वो है, अगर आप दोनों को तीनों पिक्चर्स को देखें, सो द अमाउंट ऑफ पॉकेट डेप्थ इज सेम इन ऑल द थ्री पिक्चर्स. बट ए जो है वो हेल्दी जिंजाइवा की पिक्चर है, बी में देर इज सम सॉर्ट ऑफ डिस्ट्रक्शन जो कि पेरोंटल पॉकेट फॉर्म हो गई है, एंड सी में जिंजाइवल रिसेशन हो गया है, जिसकी वजह से अटैचमेंट लॉस सबसे ज्यादा किस में है. Which of the following A, B or C has the maximum amount of attachment loss? So maximum amount of attachment loss is present in figure C. Why? क्योंकि इसमें attachment loss आप यहाँ से measure करोगे base of the pocket to C जैसे यहाँ तक. तो यहाँ इतना अटैचमेंट लॉस हो गया, इतना जिंजाइवल रिसेशन है, और ये अनकवर्ड टूथ है हमारा. सो पॉकेट डेप्थ सेम है, बट द डिग्रीज ऑफ डिफरेंट अटैचमेंट लॉस. इन ए पिक्चर दिस इज कंप्लीटली हेल्दी सल्कस, इसमें देर इज नो अटैचमेंट लॉस बिकॉज बेस ऑफ द पॉकेट और सीईजे इक्वल है, सेम जगह पे है. इसमें बेस ऑफ द पॉकेट और सीईजे में डिफरेंस है, तो अमाउंट ऑफ अटैचमेंट लॉस इज इक्वल टू द अमाउंट ऑफ पॉकेट डेप्थ. आर्बिट्रेरली मतलब मोस्टली सेम है, बट इसमें अमाउंट ऑफ अटैचमेंट लॉस इज इक्वल टू अमाउंट ऑफ पॉकेट डेप्थ एंड डिस्टेंस फ्रॉम द जिंजाइवल मार्जिन टू द सीईजे. तो दिस पॉकेट डेप्थ प्लस दिस is equal to the attachment loss in case of C. Okay. So different pockets of different depth may be associated with same amount of attachment loss. अब इसमें देखो यहाँ पे attachment loss CEJ से base of the pocket, CEJ से base of the pocket, CEJ से base of the pocket. तो इसमें pocket depth different होगी. यहाँ पे pocket depth सबसे deep इसमें होगी, देन नेक्स्ट इसमें, और इसमें देर इज पॉकेट डेप्थ ऑलमोस्ट जीरो है, बट अटैचमेंट लॉस तीनों में सेम है. तो दो सिनेरियोज हैं. इन दिस सिनेरियो नंबर 1 द अटैचमेंट लॉस इज डिफरेंट, पॉकेट डेप्थ इज सेम. और इस सिनेरियो में क्या है, अटैचमेंट लॉस इज सेम बट पॉकेट डेप्थ इज डिफरेंट. ओके. Now the area between the base of the pocket and alveolar bone, now what happens? The distance between the apical extent of calculus and alveolar crest is constant in human. This number you have to remember, it's 1.97 mm. The distance from the apical extent of the calculus and alveolar crest, you have to remember this 1.97 mm, and distance of attached plaque to bone is never. It is 0.5 mm to 2. mm. So this indicate the bone resorbing activity. 0.5 mm to 2.7 mm. So never, इसको हटा देना आप. It's not never. वो एक it was less than or equal to and greater than or equal to. Okay. So greater than or equal to 0.5 mm to less than or equal to 2.7 mm. So this is the distance of attached plaque to the bone and it indicates the bone resorbing activity. So, a gist of suprabony and intrabony pocket. This is just a gist of what I've already explained. So you can go through this, take a screenshot, and this will help you in MCQ solving. Next is periodontal abscess. What is a periodontal abscess? It is a localized purulent inflammation in the periodontal tissue. So it is known as lateral abscess or parietal abscess. Abscess localized in the gingiva caused by injury to the outer surface of the gingiva and not involving the supporting structure is known as the gingival abscess. So if the abscess, it involves the periodontal tissues, it is periodontal abscess, but abscess which is localized in the gingiva and it is caused by injury to the outer surface of the gingiva and not involving the supporting structure, it is gingival abscess. What is the pathogenesis? The extent of inflammation from periodontal pocket into the supporting periodontal tissue. So there is a formation of pocket with a tortuous course around the root. Lateral extension of the inflammation from the inner surface of periodontal pocket into the connective tissue of the pocket wall. अगर जो आपका पेरोडोंटल पॉकेट का जो एपिथेलियम है वहां से कनेक्टिव टिश्यू ऑफ द पॉकेट वॉल तक एक्सटेंड हो जाए इन्फ्लेमेशन, क्योंकि इफ यू विल नॉट ट्रीट पेरोडोंटल पॉकेट, आगे एब्सिसिस फॉर्मेशन इज वेरी कॉमन इन केस ऑफ पेरोडोंटाइटिस पेशेंट. मल्टीपल एब्सिसिस होते हैं बिकॉज ऑफ अनट्रीटेड पेरोडोंटाइटिस. ओके. So there is incomplete removal of calculus if during the treatment of periodontal pocket that act as a nidus और उसके around periodontal abscess form हो जाता है after trauma to the tooth or with perforation of the lateral wall of the root during RCT. It is also a very common cause of periodontal abscess. So classification according to the location. Abscess in the supporting periodontal tissues along with lateral aspect of the tooth, they are usually associated with the sinus, and abscess in the soft tissue wall are also there. Now microscopic features. So very common leukocytes honge, formation of the liquid which is known as pus, which is the center of the abscess. There is acute inflammatory reaction which surround the purulent area, and the overlying epithelium exhibit intracellular and extracellular edema, and there is invasion of the leukocyte. So this is the clinical features. You can appreciate this is a periodontal abscess over here, and this is a histopathological feature. ये central edema है, ये central pus collection है, which is known as the inflammatory exudate. So bacterial invasion with gram-negative cocci, diplococci, fusiform, spirochete, invasive fungi are also found and are interpreted as opportunistic invaders. Microorganisms in periodontal abscess have been reported to be primarily gram-negative and anaerobic rods. What is a periodontal cyst? Uncommon lesion, localized destruction of the periodontal tissues along a lateral root surface, most common in the mandibular canine premolar area. What could be the possible etiology of periodontal cyst? So it could be odontogenic cyst, lateral dentigerous cyst, primordial cyst, or the stimulation of epithelial rest of periodontal ligament. Usually they are asymptomatic, they are present as a localized tender swelling, and radiographically interproximally periodontal cyst appears on the side of the root as radiolucent area bordered by radiopaque line. Microscopic features क्या हो सकते हैं? Loosely arranged non-keratinized thickened proliferating epithelium, thin non-keratinized epithelium, odontogenic keratocyst. Thank you so much for your patience and time. If you have any query regarding periodontal pocket or any of your perio topic, you can mail your queries to me. This is my mail ID that I have mentioned. I'm so grateful for this opportunity to having shared whatever little knowledge that I have regarding periodontal pocket. Thank you so much. Take care. Goodbye.